So I'm going to present to you the current treatment standards for patients with ovarian cancer. You all know the typical ovarian cancer patient. She is an older woman and she comes in a poor condition with a distended abdomen. And then you give her surgery and chemotherapy, and then she recovers fairly fast. But then the recurrence comes, and the recurrence come again and again, and the interval between the recurrence are shorter and shorter. And finally, within 5 years, she usually dies. Some figures. Ovarian cancer is the 7th most common cancer in women worldwide. It's the 3rd most common female cancer after breast cancer and cervix cancer, with an incidence rate of 10 to 15 per 100,000. And it's also the 5th most lethal cancer in women. If you look at death rates in Europe and in the USA, you see that the death rates are declining. However, is this really due to the better therapies we have? We don't think so. We think that the reason that the death rates are declining is because the lifestyle has changed. Many women use a lot of contraceptives, and the post-menopausal hormonal therapies are decreasing. And that's probably the most important reason for this death rate decline. If you look, it's a little bit older slides, to the age-standardized 10-year survival, and it has been found out in England and Wales. You can see that the survival in the 70s was only 18%, and it has increased, it has doubled. It's now 35%, but it's still very low. What is the best first-line chemotherapy after primary debulking? The only thing we agreed on in the 4th ovarian cancer consensus meeting in Vancouver was that it should contain carboplatinum, AUC 5 or 6, and paclitaxel, 175 milligram per meter square, every 3 weeks for 6 cycles. And there was discussion, but it was accepted that intraperitoneal chemotherapy was an option, as was dose-dense schedules and the addition of angiogenesis inhibition. And this is a busy slide, but the only thing I wanted to show you is that there's a big difference in progression-free survival of the best arms of patients having first-line randomized trials for ovarian cancer. And you see that the difference is between 12 months and 28 months. As you can see, there's also a difference in schedules for these patients. Some have included 1C, some have included stage 4. Also, the populations are different. We have the Japanese GOG that was specifically for the Asian people. We have European people. So there's a lot of difference. What we also know is that the likelihood of response to chemotherapy increases with the interval of the treatment-free, increases with the treatment-free interval. And you see that it's almost 100% if it's more than 2 years. And this is a slide of the studies that have been done, the randomized phase 3 studies that have been done since 2010. And what you see is in the blue color, the trials that have been registered by EMA as acceptable therapies. In the green colors, those are trials that are under submission at EMA to get a registration for the market. And the light blue ones are trials that stopped their market access request at EMA, or did not apply anyhow. This was the first trial, the Calypso trial. The Calypso trial was a non-inferiority trial that compared carboplatinum with pegylated liposomal doxorubicin and carboplatinum paclitaxel. And to the surprise of everyone, there was a superiority of the carboplatinum pegylated doxorubicin with a median progression-free survival of 11.3 months compared with 9.4 months for the carboplatinum paclitaxel arm. This was with a hazard ratio of 0.82. There was a big hope that this would also translate into an overall survival, but this was not the case. And then we had the OVA 301, the trabectedin with pegylated liposomal doxorubicin versus pegylated lipodoxorubicin monotherapy. And also this trial had a favorable progression-free survival compared to the standard arm, which was pegylated liposomal doxorubicin. And there was a difference of only 2 months, almost 2 months, between the trabectedin pegylated doxo and the pegylated monotherapy doxo. Also, this trial did not translate in an overall survival gain. We had the Ocean trial. The Ocean trial was a trial with the first angiogenesis inhibitor for platinum-recurrent, platinum-sensitive ovarian cancer. And this trial had led to an overall progression-free survival gain of 4 months. The poor thing is that this trial did not have a quality of life assessment to see whether the arms were equivalent in quality of life. The hazard ratio, however, was important with 0.48. And then we had the TRINOVA-1 study, which was also a progression-free survival, had also a progression-free survival gain from 5.4 months with weekly paclitaxel compared to weekly paclitaxel plus tribananib. And tribananib is an angiogenesis inhibitor that interferes with the contact between the ANG and the Ty1 and Ty2 receptor. The idea was that this would lead to a more important gain in progression-free survival. However, it was not superior to the gain that we saw with BEV, although the patient population and the combination with paclitaxel was of course different. And the problem in this study was that there was about 35% platinum resistant, because the inclusion of this study was that patients could have platinum, 3 platinum-based lines before, but they should have, there was an allowance of platinum-free interval less than 6 months. And then we had the ICON-6, also a platinum-based chemotherapy plus cediranib or placebo. And this study was cut down by the AstraZeneca because the toxicity of the cediranib was too important. And nevertheless, this trial included the number they needed for the randomized phase 2 trial, and there was an important gain in progression-free survival of 2.3 months, although the toxicity was relatively high for cediranib. And also no overall survival gain, although the first not mature data showed an overall survival gain. And finally, we had the Hector trial with a progression-free, which looked at progression-free survival of 12 months. And what they did is that they used topotecan in the platinum-sensitive group and compared it to standards of care with carboplatin. So it could be carboplatin paclitaxel, or it could be carboplatin with Helix. And they found no difference in 12-month progression-free survival. The problem of this trial was that topotecan was given for 3 days, and the other schedules, the standard schedules, are all for 1 day. So it's less interesting for the patient and also for the logistics of the hospital to continue with this combination. And finally, I want to tell you about the olaparib OV19 study, because this was a study that resulted in a registration at EMA, but Isabella will tell you much more about this trial. But this trial had a 3.6 months progression-free survival gain of olaparib versus the placebo arm after they had a response to platinum-based chemotherapy. So if we look at the trials that resulted in registered therapies, it was the Calypso trial with the Helix, the liposomal doxorubicin and carboplatinum. It was the OVA 301 with the trabectedin, the Oceans with the bevacizumab, the Trinova 1 with the tribananib, and the olaparib trial. And what you can see is that if you look at the angiogenesis inhibitors, that especially the bevacizumab had a very favorable hazard ratio, although the olaparib even had a better hazard ratio. And all the trials were negative for overall survival. So what can we conclude now for the standards of care for platinum-sensitive recurrent ovarian cancer? If there are no contraindications for angiogenesis inhibition, carboplatinum, gemcitabine, and bevacizumab, followed by maintenance bevacizumab, is more or less the standard. If you have a BRCA germline or a somatic mutation, platinum-based chemotherapy followed by maintenance olaparib if there is a response to platinum-based chemotherapy. And if there are contraindications for angiogenesis inhibition, you can use carboplatinum with pegylated liposomal doxorubicin or carboplatinum with paclitaxel or carboplatinum with gemcitabine. And if there are contraindications for carboplatinum options, you can use pegylated liposomal doxorubicin with trabectedin or weekly paclitaxel with tribananib. Are there any questions?
Thank you, Nelleke. Questions? So I would like to, may I ask one question? Can you hear me? What I would like to ask you is, now we have reached the ceiling with chemotherapy. We cannot move any further, and we are moving to a very nice era of targeted therapy. We have two very important drugs. This question may be asked again after a few months when we have another label available, but right now we don't have it. As you showed that we have in BRCA mute population a label, and angiogenesis is there with bevacizumab. So when would you like to see that patients receive bevacizumab, and when would you like to see, and how you are going to place PARP inhibitor?
Well, at the moment, what we do is that if we test the BRCA mutation in the tumor and in the germ, and if it's positive in the tumor in the germline, and those patients who have a BRCA mutation now start with platinum-based chemotherapy, and then with maintenance olaparib. And if they don't have a BRCA mutated mutation, we start with bevacizumab. Together with the chemotherapy in the relapse
if they have
situation.
not received it in the first line.
Right.
Right. What about, can I ask the panel? Now we have 3 major countries here of Europe. Keta, in Italy.
In Italy, we have a limitation in prescription. If patient has not received BEV in first line, our general feeling is that we use BEV in first line. But if for any reason a patient has not received BEV in first line, we have a precise indication we can prescribe BEV only at the first platinum-sensitive recurrence. So it is a great challenge because when a patient recurs as platinum-sensitive, that is the last possibility for that patient to receive an anti-angiogenic agent in our treatment algorithm. And I strongly believe that we can try to increase overall survival of our patient if we are able to incorporate all the new drug will arrive in the landscape of treatment we already have. So what we discuss with the patient, but it is a challenge, I can say, if she does not receive BEV in that occasion, she will never receive the drug. So we offer BEV at the first recurrence and olaparib at subsequent recurrence. But it is a challenge.
Yeah. Isabel?
I am exactly on the same line than Keta. And when I'm looking to the PAOLA-1 trial recruitment, PAOLA-1 is dedicated to first line, and he explored the combination of PARP plus bevacizumab versus bevacizumab in maintenance treatment. And we have a very high recruitment in Europe, and I suspect that the majority of our friends use BEV in first line not to be in the situation to have to make a choice for the patients.
So in Germany, 80% of the patients receive bevacizumab first line. But nevertheless, in relapsed ovarian cancer, we have to understand, is there any indication for a pressure of remission? Does the patient have ascites? Is this patient with lymph node metastasis, what we don't operate it? So beside the BRCA positivity, I think we have to understand, do I need really a combination treatment where I induce high remission, profusion, ascites? That maybe bevacizumab is a better place. And if not, why not to go with a low toxicity treatment in a sequential switch regimen? Because if we talk about olaparib or niraparib, it's not maintenance, it's a switch treatment. It's a sequential strategy in the case of a stable tumor disease. So, but nevertheless, at the moment, in Germany, it's approved for first line bevacizumab and second line, but even in platinum resistant. So I think we have to discuss with the patient, because it's not neither nor. It's only more what treatment at what time. And we know we have always patients with really challenging platinum-based third line, fourth line. So I don't want to make it completely dependent on the availability of the drug. But nevertheless, it's wonderful that we have one more option.
So one important thing you all have said in an indirect way, that you can give BEV only once in the patient's course. So either is the initial, or is it the sensitive disease, or at the recurrent disease, because EMA has labeled BEV in all these places. Okay.
Okay, then
more
we can
questions?
continue, I suppose, because the time is over.
No. You still have 3 minutes.
I see the time. Already 1 minute.